So we are continuing bronchial asthma. We have already seen all the drugs that are used in bronchial asthma, all the mechanisms of action, its adverse effects, everything it is over. Now we will be seeing how will you treat a case of bronchial asthma. We have a lot of drugs before us. So how will we treat a case of bronchial asthma? So the choice of treatment, it is all the goals of therapy. Is actually, it is to relieve the symptoms of breathlessness and wheezing and prevent recurrent exacerbations and to minimize emergency hospitalization. So that is the goal of our drug therapy. And there are different categories of, depending upon the severity, it is classified as mild, moderate, severe, severe acute, episodic, etc. So we will be seeing one by one. So mild episodic asthma. Mild episodic asthma means symptoms will be less than once daily, and in between they will be normal. So there may be once daily or not once daily, and normal in between. So such cases we have to go for inhaled short-acting beta-2 agonist like salbutamol. So whenever there is a symptom, they can inhale this short-acting beta-2 agonist like salbutamol. So that is the step one. So it is a mild episodic asthma. Understood? Now we will be seeing the seasonal asthma. This so the persons who are having this this bronchial asthma, in some seasons it may aggravate. So some people it may be during summer, some people it may be during spring, then some in fall or winter. So they will be knowing in which season they are more allergic and more they are developing more symptoms. So before starting the anticipated the season itself, they have to start low dose inhaled corticosteroid. ICS means inhaled corticosteroid inhalation. So it should be started 3 to 4 weeks before the anticipated seasonal attack. So suppose if it is during summer, so 3 to 4 weeks, that is maybe if it is in March, in countries like India, March, then they have to start in February itself, low dose inhaled corticosteroids, and it should be continued. And also once summer is over, again they have to continue 3 to 4 weeks after the season is over, because the persons who are having or patients who are having bronchial asthma, it is really troublesome. So they have to continue till 3 to 4 weeks after the season is over. In addition, we can also add oral montelukast, they are leukotriene antagonist. You have seen already. So this is regularly daily they are taking. In between, if there is some acute attack, so it is increasing, some exacerbations are occurring, then they have to take the short-acting beta-2 agonist like salbutamol. So continuous ICS and salbutamol for the exacerbation. So that is for the seasonal asthma. Then comes, so that was step one. Then step two, it is mild chronic asthma, that is persistent asthma with occasional exacerbation. So this we are preventing, and here they are having persistent asthma, and in between there is some exacerbations. So such cases they have to somewhat similar here. Regular low dose inhaled corticosteroid and episodic treatment. Episodes should be treated with, that is exacerbations should be treated with the short-acting beta. So always think it is the short-acting, it is not the long-acting. So exacerbations, they have to treat with salbutamol. That is the short-acting beta. So that is step 2. Now we will see step 3. It is more, so the other one was, it is only mild chronic. Now this is moderate asthma. So there is moderate daily, there is asthma with frequent so in some days it will be, there is more, so exacerbations. So such cases, again, it will be low dose of inhaled corticosteroid, inhaled long-acting beta-2 agonist. So here we are combining ICS plus long-acting beta-2 agonist. So like salmeterol, formoterol, etc. So like this, see. This Seroflow, which contains salmeterol and fluticasone. So this is a steroid, inhaled corticosteroid and long-acting beta-2 agonist. So for the moderate asthma with frequent exacerbations. So this is the treatment. And in between, if there is acute exacerbation again, for that we can go for beta-2 salbutamol. I think you understood. No, so that is step 3. Now we will see severe asthma. Severe asthma, so there will be, there will be continuous symptoms. Their activity will be limited. Then, and in between there will be exacerbations, and they may be needing hospitalization also. So such cases in hospitals, either nebulization or this is the MD metered dose inhaler. It will be attached to a spacer. So this is a pediatric case, that is it is attached to a spacer. So even adults also we can use the spacer. So the inhaled corticosteroid through some spacer device, because they will be they cannot tolerate the keeping this inhaler into their mouth. So we are keeping the spacer, or we can go for nebulization also. So what are we giving? We giving inhaled corticosteroid through this spacer device plus long-acting beta-2 agonist. It should be twice daily. Severe asthma. Again, we will be seeing additional treatment for this severe asthma, severe acute. So this is severe asthma. So along with this, we can also go for that is leukotriene antagonist like Staphylococcus, montelukast, or these are orally sustained release oral theophylline, sustained release oral beta-2 agonist. And and also in between, so once this the first treatment is over, in between the exacerbations, it can be treated with inhaled beta-2 agonist like salbutamol. So severe asthma, they have to be hospitalized. We have to give inhalational corticosteroids and long-acting beta-2 plus, if needed, leukotriene antagonist or sustained release oral theophylline or sustained release oral beta-2 agonist like salbutamol. Then rescue treatment, that is inhaled beta-2 agonist. I think you understood. So severe asthma, hospitalized. So that is it. So that is step 4. And step 5 means if, so with all these things, if it is not controlled, usually the oral steroid therapy, that is the last resort. We should not give steroid in the beginning itself. We should not give systemic, oral or IV or etc. for the mild, moderate, or even for the early stages of severe asthma. We should not give oral steroid therapy. If it is very much needed only, we will go for systemic or oral steroid therapy. So that is step 5, but that should be the last resort. So we will once again we will go through now. This is the severe and acute. So severe acute asthma means status asthmaticus, continuous breathlessness. So that is status asthmaticus. Like status epilepticus, this is called status asthmaticus. So they will be needing an urgent hospitalization and vigorous therapy. So the important risk factors. So how this asthma people develop this status asthmaticus? It is maybe because of some respiratory infection or abrupt cessation. So they would have started some glucocorticoid therapy for the previous episode, and they would have stopped without the guidance from the doctor. They would have stopped immediately. So abrupt cessation of the glucocorticoid therapy can again cause such status. Then also certain drugs like aspirin, that is an NSAID. NSAID means non-steroid anti-inflammatory drugs, or inhaled allergens. So this can also increase the severity. Then emotional stress. Some people, if they are becoming angry or some emotions, it can exacerbate their condition. So these are the aggravating factors that will end up in status asthmaticus. So the patients will be marked. What are the symptoms? You will be studying again in clinical side, but we will be seeing just the points only. There will be dyspneic, exhausted, cyanosed and dehydrated. There will be tachycardia. Then pulsus paradoxus will be there. There will be drowsy, and finally there will be respiratory failure, right ventricular failure, including a gallop. So pulsus paradoxus means during inspiration, usually our BP will be falling down. We will fall to some extent, some maximum 10 millimeters. So, but here during inspiration, it is going like this. It is reduced more than 10. So this is called pulsus paradoxus. This can occur in all this asthma, it can occur. Then another thing, gallop rhythm. This is because of the right heart failure, right ventricular failure. There will be gallop. You know what is gallop? I know you will be knowing it. What is gallop? Hello. Are you all there?
Yes, ma'am.
Someone answer. What is gallop? What do you mean by? Hmm. Some boys, can you make the gallop sound? No boys are there. Hello. Should I call your name? Then only you will answer. Hello. Why people are not there? Yes, I'll call someone then. Abhishek.
Yes, ma'am.
Do you know what is gallop?
A horse running sound, ma'am.
Can you make the horse running sound?
Something like tuk-duk, tuk-duk.
So okay, so that is a sound. So in right ventricular failure, this will be that you will see hear the gallop sound. This is because usually we will hear only the first heart sound and second heart sound, but you will be hearing the S3 also. So then if the S3 is present, it may give you a gallop rhythm or a gallop sound. So that is the patients with bronchial asthma, acute severe asthma, these things will be there. So that is the okay. Now we will be yes. In addition, you can see the sternocleidomastoid muscle. There you can see the prominent sternocleidomastoid muscle, and high wheezing will be high pitched, and the breath sounds. Sometimes it will be absent breath sounds also. So all these things, if you just see examine a patient with status asthmaticus, you can all these things will be there. So this is the picture. Then, how will you treat the status asthmaticus? We have already seen we have to give everything, but on the stepwise treatment we will see. So we have to give. So because they are hospitalized, so immediately if it is severe status asthmaticus, then we have to start hydrocortisone, hemisuccinate. So this should be given intravenously. 1 minute. Hydrocortisone, this is a glucocorticoid, nebulized salbutamol, high flow humidified oxygen. Then so this, if this is not functioning, that is with the mask, if it is not happening, then you have to go for intubation and mechanical ventilation. Then treat the chest infection with antibiotics. Then we have to correct, because continuous breathlessness, there will be dehydration and acidosis. So that has to be treated with the saline and sodium bicarbonate. So one by one we will see hydrocortisone hemisuccinate. So this is the glucocorticoid, and it is it should be given first. It should be given 100 milligram IV stat. That is, stat means immediately, followed by 100 to 200 milligram 4 to 8 hourly infusion. So like this we have to start. Then salbutamol we have to give along with ipratropium. We can give, or salbutamol again, alone. And we are giving in nebulizer. Then high flow humidified oxygen, that also should be given. Then in between, you can, in addition, you can add salbutamol or terbutaline, because this inhaled drugs, it may be other drugs. No, we are giving all these inhalations. It will take some time. So we will be to reach this smaller alveoli. So you have to give salbutamol or terbutaline, IM or sub-Q. Okay. Then if this is not benefited, the patient is still breathless, then we have to go for the endotracheal intubation. So we have to put the tube, and we have to keep him on mechanical ventilation. Then I told you sometimes it may be the asthma, it would have become severe because of some infection. So the chest infection should be treated with antibiotics. And dehydration, it should be treated with saline, and acidosis with sodium bicarbonate or sodium lactate. So that was about the treatment of asthma. Now there is another condition called COPD. COPD means chronic obstructive pulmonary disease. Chronic obstructive pulmonary disease. Okay. So what is the difference? So this is an irreversible airway obstruction. Asthma, it is reversible, but this is irreversible. And the most important features that are seen in the COPD, it will be emphysema and chronic bronchitis. So what is happening here? There will be parenchymal dam because of the chronic inflammation. And one of the most important factor that causes the COPD is smoking. So smoking, if anyone is having the habit, please stop it. So the COPD, it may end up in, if regular smoking, they can end up in COPD also. So there will be, there will be chronic inflammation, and the parenchyma also will be damaged. And you know, the oxygen exchange, it happens in the alveolar, this membrane. So that will be damaged and it will be thickened, and there won't be any transfer of oxygen. So, I mean, gradually it will be decreased. That is why the patient will be developing emphysema. So it is a dilated. There is no correct form for the alveoli. It will be just dilated like a balloon. So it is not like a balloon, but it will be dilated. So that is called emphysema. And so you can see here, see all the ribs, no, it is somewhat, it become straightened, it is flattened or straightened. Usually it will be oblique like this, it will go. So this emphysema just it has become like almost straightened. So because of the expansion or the dilatation of the alveoli, and the oxygen exchange is not happening properly. And another thing, we have already seen in bronchial asthma, there is infiltration of eosinophils, but here there will be neutrophil activation. You will see more of neutrophils. And then we will see some other features also. Then, yes, I have told it is to stop smoking. That is the number one treatment we have to do is we have to stop smoking. We can also give influenza vaccine, but the main treatment, it is bronchodilators. We will see that. And when it is acute, again, we have to go for the salbutamol or short-acting beta-2 agonist. Then theophylline, it is more effective in COPD than in bronchial asthma. And theophylline, we have already seen it will increase the cardiac inotropic effect, because we have seen already, and it will increase the calcium, and it will increase the cardiac inotropic effect. So it may be of value in cor pulmonale. Cor pulmonale means the right ventricular failure. So such cases, theophylline, it is of use. And also theophylline decreases the release of, we have already seen, histamine and other mediators and cytokines from the master cells and activated inflammatory cells. So this may be of use in COPD than bronchial asthma. But what are the current therapy of COPD, that is chronic obstructive pulmonary disease? We have to give the bronchodilators, beta-2 agonist, anticholinergics. Why anticholinergics? I will tell you. Then inhaled glucocorticoid, that's only last resort. Oxygen, anyway we have to give in acute cases. Then prophylactic antibiotics we can give. Then prevention of dehydration. All breathlessness, there will be dehydration. So we have to give, prevention of dehydration. Then physiotherapy, pulmonary rehabilitation and education. So, sorry. Why this anticholinergic? Because the only reversible factor in the COPD is actually the parasympathetic tone. It is a major reversible factor in chronic obstructive pulmonary disease. So that is why the anticholinergic drugs are effective in case of COPD. So usually it's a combination of this anticholinergic and beta-2 agonist. It's given. See, you can see this ipratropium bromide. It is an anticholinergic drug plus this beta-2 selective, short-acting beta-2 agonist, salbutamol. So this is the most important combination in case of COPD. You would have seen the other, in case of bronchial asthma, it will be an inhaled corticosteroid and beta-2 agonist. long acting or short acting. But here you can see this is also effective, but this is the best treatment for COPD. That is inhaled anticholinergic plus selective beta-2 agonist salbutamol. So this combination, because I told you the parasympathetic tone is the major reversible factor in case of COPD. Corticosteroids, the inflammation, it is not like bronchial asthma. It is not very responsive to corticosteroid, and it should not be in very advanced cases only we can use this corticosteroid. But for like bronchial asthma, we are using inhaled corticosteroids in the early cases itself. But COPD, it will not be effective. The best drug is ipratropium and salbutamol, inhaled beta-2 agonist. We can go for long acting also, that is not an issue. Okay, then intermittent inhaled oxygen therapy improves the long-term survival. So oxygen therapy means it is not in the hospital. It is the home oxygen therapy, or it is also called HOT. HOT. So home oxygen therapy. So we can at home they can use this oxygen therapy. This is the many type of this oxygen cylinders are there. Sorry. So it will be, they can keeping the this tube into the nostrils, and they can work also in between. So that is because this COPD means they will be having almost daily, they will be having breathlessness. So we can go for this oxygen tube. So another one, it is the pulmonary rehabilitation. So that we have to train them how to do. Here they are just blowing the some paper. So this will increase their lung capacity. So that is inspiration as well as exhalation. So that such pulmonary rehabilitation they have to do. So such therapy is needed for in case of COPD. Then when you check the infections of this COPD patients, some viruses like the recent coronavirus is also there, rhinovirus and influenza viruses. These are the viruses causing infection in COPD patients, because there will be airway obstruction, and there will be collection of many viruses or bacteria, and there will be lower airway bacterial colonizations. Many bacteria, especially Haemophilus influenza, Streptococcus pneumoniae, Pseudomonas, all dangerous ones are there. So we have to treat them. And if there is purulent sputum, the sputum, if the sputum that is coming out, if it is purulent, that shows it is bacterial infection. So that is one of the signs. You can just a clinical marker I am just telling. If purulent sputum means it is bacterial. If it is clear sputum means it will be virus. Even if it is bronchial secretion or nasal secretion, if it is nasal secretion, if it is white means it may be allergic or viral, or if it is green or yellow like that, it will be bacterial infection. So if you see some such sputum, we have to go for antibacterial antibiotics we have to give. The antibiotics like fluoroquinolones, erythromycin, azithromycin, etc. So you will study this later. So antibiotic treatment like fluoroquinolones, erythromycin and azithromycin. Then we can also go for mucolytic agents like carbocysteine. Carbocysteine, mucolytic means all the mucus, it will be lysed. So that is mucolytic agent like carbocysteine. And the most important thing, that is give up smoking. So smoking is not at all good in case of COPD. No, it's not good for any condition. It may end up in many health problems. So we have to stop, the patients have to stop smoking. Okay, thank you. That was the last slide.